Thanks, Dr. Leith. So my name is Rob. I'm one of the R1s. Today I'll be giving my first Grand Rounds talk, and we'll be talking about stone disease, healthy lifestyle, and impact of metabolic syndrome. And thank you for having me to speak this morning. So just to go over what we'll be talking about today, we'll just have an overview on epidemiology of stone disease, as well as 24-hour urine collections, specifically 1 versus 2 collections. And then we'll talk about some specific dietary recommendations, as well as restrictions. And finally, we'll discuss the role of metabolic syndrome in stone disease. So the AUA just recently released an update in 2014 for medical management of stones. Their primary source was a systematic review in 2012, and they supplemented this by some more papers found through supplemental searches in PubMed and Embase. They came up with 27 guideline recommendations. 16 of these are classified as expert opinion or clinical principle. So it's just interesting to note that 60% of the guideline recommendations aren't based on a plethora of concrete evidence. With respect to epidemiology, about 1 in 11 people in the United States have stone disease, and the prevalence is increasing. Using the NHANES study, which is a National Health and Nutrition Examination Survey from 2007 to 2010, with an N of 12,000, they came up with a prevalence scales it all came up with a prevalence of 8.8%. And this is an increase from 5.2% from a prior NHANES study in 1994. So this is a 70% relative increase. Stone disease is more common in obese patients, more common in Caucasians, and the odds ratios for diabetes and obesity were 1.59 and 1.55 respectively. There were some limitations to this study because there's more diagnostic imaging going on now, which might lead to more diagnosis of asymptomatic stones, but the investigators tried to correct for this with a secondary outcome of asking patients whether they've actually ever passed stones. This is just a table summarizing their data, but I'll just draw your attention to the higher prevalence in older populations and the higher prevalence in both Caucasian male and female patients. They also tried to examine some risk factors, but the authors were forthcoming in that the data was not perfect. There's many metrics for stone disease, including hospital discharges, self-reported stones, autopsy findings, incidental imaging, type of imaging, but they actually think that this is likely an underestimate of stone disease. This is because of the presence of asymptomatic stones or the fact that patients may pass stones spontaneously. But one thing they saw is that with increasing weight, there was an increasing prevalence, and it was consistent that males had more stone disease than females, which we know. But what does stone disease actually cost? So Pearl in 2005, using the Healthcare Cost and Utilization Project, estimated the annual cost in the year 2000 for stone disease to be $2.1 billion. If you convert this to 2014 dollars, it's $2.81 billion. Antonelli in the Journal of Urology in 2014 published a paper, and they took this prevalence and extrapolated it based on increasing population. So they extrapolated the year 2000 data, and in 2007 they projected it would be 3.8 billion, and by 2030 it would be 4.57 billion dollars per year. This is partly attributed to increasing population as well as increasing prevalence of both obesity and diabetes. And these two factors alone were estimated to add $1.24 billion per year by 2030. And again, this is actually likely an underestimate of cost because we know that the cost of healthcare is outpacing the rise of inflation. Again, this was using the NHANES data as well as the Urologic Disease in America Project data. And this also assumes that the prevalence of stone disease stays the same, but as we've seen before from 1994 to 2007, 2010, the prevalence is actually increasing. So who should we be evaluating for stone disease? The AUA has some guidelines which are similar to our CUA guidelines, in that clinicians should perform screening evaluations for patients with newly diagnosed stones. This consists of history and physical, serum chemistries, urinalysis, and that additional metabolic testing can be performed for patients that either seek this or are high-risk stone formers. The AUA guidelines say that metabolic testing should consist of 1 or 2 24-hour urines and don't give a specific recommendation either way. Looking at the algorithm from our CUA guidelines, it's similar in that stone patients first have an initial screening evaluation, and if they're high risk, can proceed to 24-hour urine collections, in this case 2. So that brings up a good question: should we be doing 1 or 2 24-hour urine collections? So a paper by Castle in 2010 looked at this, and they had a retrospective review of about 800 patients. They had 2 24-hour urine collections within 72 hours of each other. They found that there was no significant difference in any of the 12 parameters, so the authors concluded that only 1 24-hour urine was necessary. In the same paper, though, when they look at the data a little bit differently, this is where they look at the absolute value of the difference in each parameter compared to 0, and they actually found that there was some significant difference for most of the parameters except for creatinine, potassium citrate, and phosphorus. Another paper by Healy in the Journal of Urology again looked at about 800 patients with 2 24-hour urines over 10 days. They found that only the urine volume and phosphorus were significantly different. They've also found that there was a change from abnormal to normal or vice versa result in between 5 and 45% of patients. And so they postulated that this could actually impact clinical decision making, and that they recommend 2 24-hour urines. In this Canadian study in 2012 by Nyan et al., again, they looked at around 200 patients who had 24-hour urines on consecutive days, and they did the statistical analysis where they compared the mean differences for each parameter to 0, and they found that there were significant differences for every parameter. And again, there was this finding of an abnormal to normal or vice versa change in 17 to 48% of the results. So in our CUA guidelines, authored by our very own Dr. Patterson, the recommendation is detailed medical evaluation with ideally 2 24-hour urine collections. It always looks like that. So when should we be doing these 24-hour urines? So according to the guidelines, at least a single 24-hour urine needs to be done within 6 months of treatment initiation, and this is to assess metabolic response. And then in terms of follow-up, annual 24-hour urines. This could be either more frequent or less frequent depending on patient stone response. Some of our practitioners here actually extend this to 2-year imaging intervals with follow-up with the GP. The reasoning behind this is that if patients aren't having active stone disease, then whatever they're doing is working. So taking a more pragmatic approach to it. So now we'll move on and talk a little bit about diet. So D et al. In 2014 just looked at the trends in food consumption in the United States, and they looked at the Economic Research Service, which uses data from the U.S. Department of Agriculture. They had 250 documented food types they looked at since 1950, and they used Spearman correlations to compare diet and components of diet to stone prevalence. They found that there's increasing stone prevalence, which correlates with rising caloric intake, fat, protein, fruit, and vegetables, specifically dark green vegetables, which we know contain a lot of oxalate. They found positive correlations between dark green vegetables, flour and cereal, corn products, all which contain oxalate, as well as added sugars. And they noted that we're eating actually 25% more than we used to, and this puts us at risk for stones. This is correlated with increasing rates of obesity and diabetes, which are both independent risk factors for stone disease as well. But does changing our diet actually do anything when it comes to urine composition? So Kirak in 2013 looked at this. Patients had a baseline 24-hour urine, and then were given a study diet which was targeted at their specific urine abnormalities, and a repeat 24-hour urine was done a month later. This is a prospective study, and they found that 86% of patients had at least 2 abnormalities, the most common being hyperoxaluria, and that after the 1-month study diet, all of these abnormalities were correctable except for calcium. So we know that diet modification can change urine composition, but how does this translate into actual stone incidence? So in this seminal paper by Borghi in 2002, they did a prospective randomized control trial, and this is one of the first big RCTs for diet and stone disease, and they compared a low calcium diet to a normal calcium, low protein, low salt diet. This was in 120 men, and they found that there was less recurrence on the low protein, low sodium, normal calcium diet, with a relative risk of 0.49, and this was 0.37 when adjusted for stone episodes prior to study randomization. They included patients with 2 or more calcium oxalate stones, hypercalciuria, They were on an unrestricted diet, and they had no other medical conditions associated with stones. Just looking at their data, you note that between the two arms, they stay relatively similar for the first 24-30 months, but then they start to diverge. So the thinking behind this is actually that early recurrences between the two arms were from high-risk stone formers in both groups, or patients had undiagnosed stones before the study was started. And the thinking behind why there's a difference between the two arms is that in a normal calcium diet, calcium was binding oxalate in the intestinal lumen, allowing it to be excreted, decreasing oxalate absorption, and that the low animal protein diet decreases endogenous oxalate synthesis. One criticism of the study, though, is that they weren't really comparing apples to apples, and that the two arms had different dietary components. So in one there was low calcium, but in the other arm there was 3 different dietary modifications. So what about the relationship between calcium and oxalate? So both hypercalciuria and hyperoxaluria are independent risk factors for stone formation. We get about 50% of our oxalate from diet, and this is also a risk factor for stones. Dietary calcium primarily affects oxalate GI absorption by binding oxalate in the gut, allowing fecal excretion. But as long as recommended daily intake, which is about 1,000 to 1,200 milligrams a day of calcium, is achieved, then oxalate supersaturation is unchanged. And this was in a study by Lang in 2012, which we'll talk about in a minute. But with respect to calcium specifically, how does it impact stone risk? So because calcium is a component of many different types of stones, it was previously believed that increased dietary calcium was a risk factor for stones. But actually the inverse has been shown to be true, in that low calcium actually increases stone risk, and this is due to increased oxaluria. A study by Sorensen in 2012 looked at the Women's Health Initiative of 80,000 postmenopausal women using validated questionnaires, and they found that daily calcium intake was 39 milligrams lower in stone formers, that calcium supplementation was less common in stone formers, and that increased dietary calcium decreased stone incidence by 5 to 28%. Also interesting to note that in this study, 80% of the women were having less than the recommended daily intake of calcium, which is 1,000 to 1,200 milligrams per day. But does it matter when we take the calcium? Should we be taking it with food or separately as supplements? So Lang looked at this by having patients on a balanced diet with equal proportions of calcium and oxalate throughout the day, compared to an imbalanced diet with a higher calcium load at breakfast and lunch, and then a large oxalate load at dinner. And the purpose of this was to determine whether the ratio of calcium and oxalate at mealtime can affect absorption and excretion. The total daily intake for the study was 1,000 milligrams of calcium, which is the RDI, and 750 milligrams of oxalate. So looking at just the urinary calcium from the study, the white is the balanced diet and the black is the imbalanced diet. The urinary calcium was higher in the imbalanced diet. It was lower if taken with oxalate. But they also measured supersaturation of calcium oxalate using the Tiselius index, and the supersaturation remained the same, even though there was higher urinary calcium. And just some details about the study. The patients were on a diet for a week. They had urine collections in the last 4 days. They had a washout for a week and then were switched to the other diet. And looking at urinary oxalate, again, white being the balanced diet, black imbalance, the oxalate is not generally affected when they're on either of the diets. There was a dip from 1 to 6 p.m., and the authors concluded that this is probably from calcium being loaded into the colon from breakfast and lunch and sitting there during the afternoon, early evening period. And this allows more crystallization with oxalate and oxalate excretion. So for urinary oxalate and calcium, we recommend taking the RDI, which is about 1,000 to 1,200 milligrams per day, and this can lower oxalate levels. Taking calcium with meals might lower urinary calcium, but again, the clinical significance of this is unclear because supersaturation of calcium oxalate remains the same. So if calcium is important, should we be supplementing it? So we know from that study in 2012 by Sorensen that calcium supplementation was less common in stone formers. Interestingly, a paper by Wallace in 2011 from the same study population looked at calcium and vitamin D supplementation. This was associated with a 17% increase in self-reported stones. However, patients in this study were taking 1,000 milligrams of calcium supplementation as well as 400 international units of vitamin D. We know now that the recommended daily intake of vitamin D is actually 1,000 international units, so there may have been not enough calcium absorption, leading to more calciuria. Curran in 1993 actually looked at 45,000 men aged 40 to 75, and they found that higher dietary calcium was actually inversely proportional to stone incidence, with a relative risk of 0.56 in the highest quintile of dietary calcium intake. So it's probably best to aim for a normal calcium intake of 1,000 to 1,200 milligrams a day, and it's probably safer to take it with meals. In terms of oxalate, there are many oxalate-containing foods, as we all know, and some of these foods are parts of healthy diets, including spinach, kale, nuts, certain fruits. And given its ubiquity, it's very difficult to prescribe a low oxalate diet, and arguably it really would impact lifestyle as well, or quality of life, I should say. And also, is it really necessary? Because we've seen that a normal calcium, low animal protein, low salt diet can effectively decrease oxalate excretion on its own. So Taylor in 2007 just looked at some components in our diet which contribute to oxalate. And as you can see, it is quite ubiquitous. But one thing is that spinach is actually a major contributor. So if we are recommending cutting oxalate or reducing oxalate in the diet, maybe a better strategy is to maybe focus on the biggest contributor, which is spinach, which leaves patients open to have other healthy foods. But does restricting oxalate in the diet actually make a difference? So Nuven in 2012 looked at this, and they gave patients either a low oxalate diet or a recommended daily intake calcium diet with low animal protein, low salt, and patients were unrestricted with their oxalate. Both diets had a decrease. In the low oxalate diet, it was 45.9 to about 40.2 milligrams, but there's actually a much greater decrease for the patients on the recommended daily intake of calcium diet. So they concluded that a normal calcium diet is better than restricting oxalate alone. And they thought that to decrease GI oxalate absorption leads to more excretion from the increased calcium intake. This is just a table looking at the results. Well, I'll just draw your attention to the components. So obviously the oxalate, which we talked about, there was a greater decrease on the study diet, but also body weight too. So patients that were on the recommended daily intake of calcium, low animal protein, low salt diet actually ingested less calories, and there was a decrease in BMI. So there was the added benefit of weight loss and reduced salt intake, as patients who were on the study diet had a third of the salt intake as patients on the low oxalate diet. So now that we're talking about salt, what is its role within stone formation? So increased salt load increases urinary calcium excretion, and low sodium in the diet has been shown to decrease both calcium and oxalate excretion in the urine. Nuven again in 2010 looked at a low sodium diet for 3 months and found that there's a 38 and 34% reduction in calcium excretion for men and women. And they actually calculated that 100 milliequivalents of sodium chloride reduction was the equivalent to 80 to 100 milligrams reduction in calciuria, which is similar to the thiazide diuretic. So we're able to achieve a pharmacologic type response just with conservative dietary recommendations. This was a randomized control trial with 200 patients, and the study arms were water therapy, or counseling patients to achieve 2 to 3 liters of urine output per day, versus water therapy plus a low salt diet. There was also a 70% decrease in urinary sodium in patients on the low salt diet. Again, here's a table just summarizing their findings, showing that there's decreased calcium as well as oxalate on the study diet. The reason for this is that in the distal tubule, calcium and sodium share a common transporter, and the idea is that if there's more sodium taking up the transporter, more calcium is left in the renal tubule, and more calcium is left in the urine, therefore. Also, excess sodium can lead to subclinical chronic metabolic acidosis, which can lead to some increased calcium release from the bones. So when we're talking about low animal protein, low salt diet, one thing that comes to mind is the DASH diet, dietary approaches to stop hypertension. The DASH diet by nature is actually higher in oxalate-rich foods because it's promoting a higher intake of fruits and vegetables, including dark green vegetables. But this is partially offset by increased calcium as well as citrate. So a study by Nori in 2014 looked at patients on the DASH diet, which is a calorie-controlled, low-salt DASH diet, versus low oxalate diet alone. Their primary outcome was calcium oxalate supersaturation. They found that on the DASH diet there was higher urinary oxalate, but actually decreased calcium oxalate supersaturation. Of note, the results, they weren't statistically significant. They were trends either way, but it was interesting because it's sort of a contradictory result with increased urine oxalate but decreased supersaturation. So for the DASH diet, we don't generally recommend limiting oxalate because there's many healthy oxalate-containing foods, including fruits and vegetables. The DASH diet has a lot of citrate from the increased fruit intake. We recommend a normal to high calcium diet of 1,000 to 1,200 milligrams per day. And again, this is because what we talked about earlier with calcium binding oxalate in the GI tract. DASH diet also includes low sodium, low animal protein. So what's its role within stone disease? So it's showing promise because there's some evolving evidence showing decreased urinary calcium oxalate supersaturation. It's also the added benefit of it being good for overall cardiovascular health. The authors said from their study that patients on the DASH diet were totally unrestricted for oxalate, and so there may be a role for some oxalate restriction, but we have to be careful with this because we looked at oxalate restriction on its own, and that hasn't been shown to be terribly effective. But if we were going to promote or combine this with the DASH diet, perhaps the best way to go would be to eliminate the most major contributor, which is spinach. So in summary, for dietary recommendations, we want to aim for a normal calcium, low animal protein, low salt diet. Some restriction might be useful, but mainly the most contributing factor, which would be spinach. Obviously, counsel patients to aim for adequate fluid intake, and there is some evolving evidence for the DASH diet. When talking about the DASH diet and BMIs and low salt intake, it brings into question metabolic disease and how what its role is within stone disease. So metabolic disease is a disease of energy utilization and storage. There's some specific World Health Organization criteria, and that is insulin resistance plus 2 of the following, and that's either patients being on antihypertensive medication or a blood pressure of greater than 140/90, high plasma triglycerides, low HDL, and elevated BMI over 30. So does elevated BMI have any effect on the urine? And so Shavit in 2015 looked at this. They looked at 2,000 patients, 40% of which were overweight, 20% which were obese. They found there was no difference in urine volume or magnesium, but there was a significant difference for urine calcium, oxalate, sodium, and uric acid. They found that uric acid stone formation was positively correlated with increased BMI, and that there was a higher probability of calcium oxalate, uric acid, or mixed stones in patients with elevated BMI. So that's for urine parameters, but what about actual stone risk? So this paper from Taylor in 2005, published in JAMA, showed that there was an increased relative risk for stone disease, basically in all groups, men and women, both that were over 200 pounds or had elevated BMIs. The data from this was from the professionals follow-up study for males and the nurses health study 1 and 2 for females. It was a prospective study of 5,000 patients, and the effect was most pronounced in the younger female population. So insulin resistance is another component of metabolic syndrome. In the study, again by Taylor in 2005, again published in JAMA, looked at diabetes and its associated risk with stone disease. They found that there was increased relative risk of stones if a patient had diabetes, 1.29 and 1.6 for women. Interestingly, though, for men it was 0.80, which is a bit unexpected. They postulated that the reason for this was that the men in this study were of a much older age cohort, and that insulin resistance actually precedes the official diagnosis of type 2 diabetes by often decades. And patients in this study with previous stone disease at baseline were excluded. So they think this might have skewed the results a little bit. But if patients had a history of stone disease, there was an increased chance of them also having diabetes, and this was for both men and women. So what else does metabolic syndrome do? Well, one other thing it does is it lowers the urinary pH. This was a paper by Maloof in 2007, and they looked at 24-hour urine pH in non-stone formers with elevated BMIs and clinical features of metabolic syndrome. And they found that with more features of metabolic syndrome, there was a more drastic lowering in the pH. This is correlated with the insulin resistance. This is relevant for uric acid stones, which thrive in a low pH urine environment. This was independent of other factors that affect urinary pH, such as age, creatinine clearance, gender, and urinary sulfate. So why this actually happens is not very well understood, but either it's from increased acid excretion or impaired buffering. It's thought that insulin actually affects acid-base homeostasis, specifically with ammonium production, which is used as a buffer in the renal tubule. So in general, elevated BMI is not good for patients with stone disease. There's increased uric acid stone prevalence in patients that are overweight or metabolic syndrome, higher probability of stones in overweight patients. BMI has been positively correlated with increased stone formation, as we've seen earlier. This effect might be more exaggerated in women, specifically younger women, but it is applicable across all age and gender. And metabolic syndrome on its own has been associated with changes in urinary pH, specifically acidification. So for patients that are overweight, should we be recommending dietary recommendations? Can they follow dietary recommendations? This is sort of a cynical study done in 2014 by Torricelli looking at this. And they looked at 200 stone formers who had BMIs less than 30, between 30 and 40, and over 40 to see whether or not they could actually follow dietary recommendations and what the impacts were. And their results showed that there was significant improvement in all groups, and actually the greatest improvement in oxalate reduction was in the super obese patients. So obviously, yes, both for ethical reasons, but also the literature shows that obese patients do certainly benefit from dietary counseling, and of course we should be offering this to all patients. So just some summary points from today's talk. So stone disease is quite prevalent. The prevalence is increasing, and it's associated with very significant healthcare costs. With respect to urine 24-hour collections, 2 collections are likely ideal. In terms of dietary recommendations, you want to aim for a normal calcium diet of 1,000 to 1,200 milligrams a day, as well as decreased animal protein and low salt. And there's some evolving evidence that the DASH diet may have a role within stone disease. We want to obviously promote adequate fluid intake, aiming for urine outputs of 2 to 3 liters a day. And oxalate restriction, there hasn't been a lot of evidence for it so far on its own, but if we're combining it with something like the DASH diet, then it might be more beneficial just to focus on the major contributor, which is spinach, allowing for intake of other high oxalate healthy foods, such as kale and nuts and other fruits. And that metabolic syndrome on its own can increase risk for stone disease. So a lot of the recommendations we talked today, healthy diet, DASH diet, weight loss, exercise, reducing metabolic syndrome, the benefits of this go beyond mitigating risk for stone disease and is actually part of whole patient health. So the urologist can play an important role in counseling patients, not just in improving their outcomes within stone disease, but also their cardiovascular and health in general. So I'd just like to thank Dr. Chu for all his guidance and helping me out with this Grand Rounds presentation. And any questions?